All right. Well, thank you everybody joining us for the Ultrasound Grand Rounds this week. Pretty excited about kind of continuing this on for the year. We've had a bunch of good talks already. And today we're pretty excited to have one of our residents, Dr. Michael Pergola, presenting today. He is part of our ultrasound track and one of our ultrasound interested residents. So he's been a good guy to have with us on rotation and throughout his years here at Metro. So without taking any more time, I'm going to turn things over to Mike. And Mike, go ahead and take it away and share kind of what you have presented for us today.
So basically starting off with just using ultrasound in the emergency department for evaluation of painless vision loss. Start off, I have obviously no disclosures, despite my best interest. I wish I could. I make no money from this. Start with a case, just real basic generic kind of overview. We'll call it a 65-year-old man, history of hypertension, diabetes, coming in for vision loss. In this case, we'll say he woke up with his symptoms. It's going to be his left eye only. He doesn't have a headache or any pain in his eye, no numbness or weakness anywhere else. He doesn't have any trauma. He's got no other complaints. He's going to be boarded back or sent back to West. So quick, if there was someone younger on here, differential we'd have, in the eye, things like retinal detachment, a vitreous hemorrhage, a central retinal artery occlusion, bolded here because kind of we'll talk more about vein occlusion, a CVA or something like optic neuritis, also something to keep on the differential here as you're working this person up. Quick little overview of eye anatomy, as most of us all hate the eye, myself maybe very chiefly included in that. Anterior chamber here, kind of things that we evaluate more with slit lamp or Woods lamp, stuff we do, at the bedside without any kind of advanced imaging. Posterior chamber here, more where we're, checking out with ultrasound. You've got your vitreous body, you've got your retina, which is attached to the choroid, and then your optic nerve. Importantly, here's the macula, which is going to be lateral to the optic nerve. So if you're looking at this eye, you'd say this is the right eye. Two things here. So kind of looking at this, going back through the anatomy again now with ultrasound. The top of the image here is going to be where your probe is. So you've got your gel, eyelid, cornea, iris, and here's your lens. This big anechoic area is the vitreous, and then you've got your more hyperechoic retina kind of plastered against the choroid with your optic nerve sheath here. Doing the scan, just the basics of the scan, you want to use a lot of gel to kind of fill in these spaces, get rid of the air in the view. Do this with or without a tegaderm over the patient's eye. When I did this in medical school, when I first learned to do it, they let us try it both ways. I found it more comfortable personally having it without the tegaderm. So when I've done this, I do without the tegaderm. You'll take your linear probe, turn the gain down so that you can get this nice, anechoic vitreous here. And you'll want to use really light pressure because you're over someone's eye. There's a sensitive part of the body to push on. I actually take a little bit of issue with this image. All images that I found on Google were someone kind of holding the probe a little higher up. I would really recommend holding it closer to the base, resting your palm so that you're not putting pressure accidentally on this person's eye. Start off with maybe what I think is going to be the most important for us clinically, which is going to be retinal detachments. This is kind of when we talk about the retina becoming detached from that choroid. Clinical history going along with it. A lot of times folks will have some preceding symptoms, the flashes and floaters you hear about. Flashes being that like traction on the retina, and the floaters being some hemorrhage and some debris in the vitreous, kind of affecting their visual fields. This is going to be, again, painless unilateral vision loss that can kind of be affected anywhere. It can be central vision, it can be peripheral vision, it can be all of your vision, depending on how much of the retina is detached and where. Patients who are awake when this happens will often describe this as kind of the curtain closing over the eye. As far as the detachment goes, there's three subtypes if you want to get into kind of some pathophysiology here. There's rhegmatogenous, exudative, and tractional causes of retinal detachment. And just we'll briefly pump into that. This rhegmatogenous is the most common kind of detachment. that is going to be fluid coming from the vitreous, going through a retinal tear, causing the retina to become detached from the choroid. Sometimes this can be traumatic, but it is certainly not always. And this is kind of the most, your cliche patient is going to be a male over the age of 45. Other two types, a little less common, your exudative detachments. This is going to be fluid collecting from the retinal vessels, kind of exuding into the space there. This can be from hypertension. It can be from things that cause leaky vessels like preeclampsia or nephritis, vasculitis. This can also be due to like elevated ICP or retinal vein occlusion where the flow is not really getting out. And then finally, this can be like a tractional cause. This can also be due to trauma. This is like the retina being pulled off by those fibrinous bands. Trauma, diabetic retinopathy is a risk factor. Folks who have sickle cell anemia can be at risk. And then folks who've had prior vitreous hemorrhage with some scarring that comes from that are at further risk. When you're doing this ultrasound, again, kind of we go through it the way I talked about earlier. Look at all these in transverse here. A really important part of evaluating this is kind of what part of the retina is attached. So you'll see the retina here is going to be this hyperechoic, somewhat thick part of it's going to be right there at the back of the vitreous. One thing you'll importantly see is that no matter what part of the retina is detached, it will always be tethered here at the optic nerve. The importance of the evaluation is if you think the macula is on or if the macula is off. The macula is, of course, where we get our best visual acuity. If the macula is still on, this becomes a time-sensitive emergency. This is the one where you want to call ophthalmology. This patient needs emergent repair to prevent any worsening of the tear and further morbidity with vision loss in that eye. The macula is already off, which in this image here, you would say the macula is definitely going to be off. This is a pretty poor prognosis, regardless of when it's repaired. Studies looking at repair within 24 hours versus as far as 7 to 10 days down the line didn't show any difference in prognosis or functional outcomes, unfortunately. A important thing to know exists, so you kind of know what you're looking at, is a posterior vitreous detachment. This is something that can be easily confused for retinal detachment on ultrasound. This is kind of the vitreous, like the layer of the vitreous separating from the retina. This can actually just be a normal part of aging. This is not necessarily definitely not an emergency. This is not even sometimes abnormal pathology. Clinically, folks who have this will kind of, describe some floaters because again, there's something floating in that vitreous. And as they increase, you get worsening of the detachment. But this is really non-emergent. This is not something that needs to go directly to ophthalmology clinic. But like I said, it's important to differentiate from a retinal detachment. The way you're going to tell the difference, again, the retinal detachment is going to be tethered at the optic nerve. Vitreous detachment, you can kind of see going all the way across the eye. Retinal detachments, we'll look at a video here in a second. They're not going to be extremely mobile with motion, whereas a vitreous detachment will kind of, as the patient moves their eye, will continue swirling in that vitreous cavity. And a retinal detachment is going to be thicker and more echogenic than the posterior vitreous detachment is going to be, which is why this evaluation with low gain is going to be helpful. Here is going to be kind of an example of a retinal detachment. Sorry. Oh, went a little faster than I wanted to. Again, see your optic nerve. You see that it's tethered. You see this thicker, more echogenic line for a pretty significant detachment here. You'll see as the patient moves their eye, a little bit of motion, but not much happening there. Contrast that with a posterior vitreous detachment. Even off the start, you can see all across the eye, not necessarily tethered at the optic nerve here. And as this patient moves their eye, it's going to continue swirling throughout the posterior chamber. And again, looking at it, it's also a little bit thinner, less echogenic than the retinal detachment was. Kind of next, moving down the differential, it's going to be vitreous hemorrhage, which again that's going to be blood in the vitreous cavity there. Very small amount of blood needed to have some pretty significant decrease in vision. I saw in some studies 10 to 15 microliters of blood can cause a decrease of visual acuity down to only hand motion. Some risk factors to develop vitreous hemorrhage is going to be diabetic retinopathy, just advanced age. Anyone with a bleeding, like a blood dyscrasia, is going to be more likely to bleed here as well. Some tumors, if you have like a retinal tumor, you can have a increased chance of bleeding. And then if you've had a posterior vitreous detachment, you actually are at risk for the vitreous hemorrhage as well. Interestingly, there's something called Turson syndrome, which is kind of basically a vitreous hemorrhage associated with some sort of other intracranial pathology. I have the study here listed in case anyone wants to dig further into it, but the study quotes that 19% of folks with subarachnoid hemorrhages will also have a vitreous hemorrhage associated with it. This is non-traumatic, and then 3.1% of TBIs are going to have an associated vitreous hemorrhage. So if your patient is, had a TBI or subarachnoid, is having some trouble bleeding or trouble seeing from one or both eyes, this could be your culprit, something to evaluate. Vitreous hemorrhage on ultrasound is going to look like a lot of debris and kind of heterogeneous material here in the posterior chamber, usually layering towards the back. And that's going to be kind of your hemorrhage that causes the vision changes here. Here you see this kind of heterogeneous area. That's your hemorrhage. As a patient, you have to have them look left, look right. You'll kind of see some swirling of this hemorrhage and debris in the posterior chamber here. Not sure how well that's showing up. It's not looking as good on my screen right now. And then the final thing we're going to talk about as far as like this differential for, in the eye pathology as a, source for unilateral vision loss is going to be central retinal artery occlusion. It's going to be an embolic event to the retinal artery, as we all know. It's going to cause some sudden painless vision loss. Usually this is carotid plaque rupturing. And of course, folks who are in risk for carotid plaque would be older folks, people with hypertension, diabetes, and also specifically for the central retinal artery occlusion, people with glaucoma can be at increased risk as well. Two things you may see with central retinal artery occlusion, one more well described than the other. The major thing that I wanted to bring up was this spot sign, which is this hyperechoic, small, looks like, a millimeter, 2 millimeter area right here. Shows up within the optic nerve sheath. This is going to be sometimes present. It's certainly not 100% of the time going to be there. But depending which studies you look at, it's going to be present between like 31 to 59% maybe of cases where it was evaluated for. So sometimes, not always, but something you can find. And then the other thing that has been even worse, more poorly described, is this optic sheath edema. They're calling, some of the stuff I looked at called anything above 0.5 centimeter to be kind of worth considering as a, finding that might be going along with this diagnosis, thinking loss of forward flow, presence of posterior edema. That's pretty much it. I was going to do a plug if there's any, earlier residents or students on, just to, a lot of the stuff I was looking at here when I was going through making this talk came from some EM blogs. Ali EM, Life in the Fast Lane are both two things that if you're kind of going through a topic in EM that you want to get a quick overview on, these are kind of great resources. And then I got the videos from Ali EM.